Hello, my name is Dr. Gilly Munavali, and I'm a board-certified dermatologist, and I practice in Charlotte, North Carolina. I'm medical director of Dermatology Laser and Vein Specialists of the Carolinas, which is right in the heart of downtown Charlotte. I also have advanced fellowship training in cutaneous oncology and cosmetic laser surgery. Our practice involves the treatment of patients with skin cancer and precancerous lesions, so we're uniquely qualified to talk about the benefits of photodynamic therapy. PDT stands for photodynamic therapy. Photodynamic therapy is a two-step process. PDT in the first step involves applying a photosensitizing agent, and that agent is typically aminolevulinic acid or methylaminolevulinic acid, and both those are naturally occurring compounds. Once those compounds are applied on the skin, the next step is activating those compounds, and we use a photosensitizing light source such as a blue light or a different laser to activate the compound in the skin and specifically in the target cells and selectively destroy those. Okay, there are two currently available photosensitizing agents used worldwide for photodynamic therapy. In the United States, the chief one that is used is aminolevulinic acid, or ALA. Outside the United States, and specifically in Europe, methylaminolevulinic acid is used. Both of these agents operate in the same manner. They operate in the presence of oxygen inside the cells, and after conversion to protoporphyrin IX, they are activated by a light source. Aminolevulinic acid in the U.S. is FDA approved for the treatment of actinic keratoses or precancers of the skin. In this process, the compound is applied and incubated over a certain amount of time, and the initial studies showed overnight incubation, followed by activation with a light source, and in this case, a blue light source. Methylaminolevulinic acid is a little different. It's applied, and the incubation time was shown to be approximately 3 hours. That light source required to activate that is a red light source. The reaction which converts these sensitizing agents to its target agent, which is protoporphyrin IX, occurs after absorption of these compounds into sun-damaged cells or metabolically active cells. This is a preferential absorption. It's a very selective process, which means that we can selectively target and destroy certain cell types in the skin. Once this process occurs and the conversion is made to protoporphyrin IX, we can take advantage of the absorption spectrum with several different wavelengths of light, the chief source of which is blue light, to activate these compounds and destroy the sun-damaged cells. Levulinic acid has several different absorption peaks, and we can take advantage of each of these peaks by using certain wavelengths of light which are really highly absorbed at these different peaks. By doing that, we get the maximum activation of this compound inside the cells. When the compound is activated to protoporphyrin IX, there are several different singlet peaks on the absorption spectrum of this compound that can be activated by different light sources, the chief one being the activation in the 400 nanometer range by a blue light source. Further down in the absorption spectrum, there are smaller peaks, and these peaks correspond to different wavelengths of lasers that are commonly used for cosmetic procedures. These can be the 532 nanometer laser, the 585 or 595 nanometer laser, and the broadband light source called intense pulse light. This is really dependent on the absorption spectrum of this protoporphyrin IX, which light source we use. With photodynamic therapy, we've seen the photosensitizers that are used, aminolevulinic acid and methylaminolevulinic acid. Both are used topically, of course, but you need an activating blue light source. And these are two examples of activating blue light sources. This one in particular has a U shape to it, and you can see the bulbs here. And what would happen is the patient would be positioned in between the bulbs with their face, about an arm's length away or so from the bulb itself, but adequate distance to get exposure to the whole face. The machine would be turned on, and they would actually be in the machine for about 17 minutes. There's an automatic timer for that. And this blue light has the advantage of being able to treat the entire face at one time, or it can be rotated around to treat other areas of the upper body, such as the scalp, for example, or an upper arm or so. This is another type of blue light unit that's used to activate aminolevulinic acid. And this one has the advantage of being flat, and you can see the bulbs here with a little grid. So the patient would sit perhaps with their face about here, and we would turn the light on, and again it would stay on for about 17 minutes, and the patient would get full exposure. Now the benefit of having a flat light like this is you can also expose flat areas such as the arms, the chest, or the back. And that's the great advantage of this particular unit. So not only can we treat sun damage on the face, but now we can treat sun damage in non-facial areas, areas such as the V of the neck or the arms, the extensor forearms that just get a lot of sun over the years as well. And lastly, in between the two devices is a cooling unit. And this unit is really, I think, pretty important to maintaining the patient comfort during the treatment. Of course, you can always use a fan as well, but this particular unit, the patient can actually hold this in their hand, and once it's turned on, it emits a cold, basically a forced air cooler. So it pushes cold air out, and the air is very chilled in comparison to room temperature air. The patient can direct that, so if there's any stinging or burning on the patient's part, then that immediately cools it down. And so this unit has the advantage of being able to roll around, and we can use it in any room we want, but typically it's used for both these blue light units during treatment. The treatment of AKs, or actinic keratoses, in the United States in a dermatologist's office is a very big problem. Actinic keratoses at their heart are premalignant lesions. So as we tell our patients, and as the literature supports, anywhere between 1 to 10% of these lesions may go on to form a skin cancer over time. So it really behooves our patients and ourselves to treat these all with malignant potential and treat them accordingly. They are formed by chronic sun exposure and DNA damage in the cells, specifically in the epidermis of the skin. This process takes between 20, sometimes 30 years to happen, so the patients may not recognize that the sun damage they had as a child or as an adolescent contributed to the formation of actinic keratoses as adults. These lesions will appear to us in patients as persistently scaly areas that don't improve over time, that can sometimes be painful, that tend to progress on and become even more scaly over time. Now, 1 to 10% of these lesions will become a skin cancer, and this is typically a squamous cell carcinoma of the skin, and that is a situation that does require surgical intervention. Photodynamic therapy, or in the U.S. the use of amino-levulinic acid as the photosensitizing agent, is an excellent way to destroy actinic keratoses and thus prevent skin cancer in the future. In our practice, we started using photodynamic therapy to treat actinic keratoses, chiefly because we were looking for an option to prevent us from having to do all the skin cancer surgery that we're doing in this day and age. Every year, the incidence of skin cancer in this country is rising, and in our practice, we see that by the increased numbers of surgeries that we perform. Using a surgical procedure is a very invasive way of treating a skin cancer, and it would be much better if we could prevent the skin cancer from forming by using a topical therapy that really suppresses the premalignant lesions. We've used many therapies in the past, and over the past 4 to 5 years have really found that photodynamic therapy with the use of ALA has been the best way to suppress these actinic keratotic lesions and prevent the formation of skin cancer. The on-label usage of ALA for PDT involves an application topically of this compound, followed by an incubation period in which the compound is absorbed into the skin. This can typically happen overnight. Once this compound is absorbed, a blue light source is required to activate the compound and destroy the cells. We've been fortunate over the past 4 to 5 years to have some really well-designed randomized clinical trials which have shown us as dermatologists and clinicians that overnight incubation, as shown by on-label usage, is not necessarily needed to achieve the desired destruction of actinic keratoses. We have found that 1 to 3 hour incubation of ALA in this topical application on the skin can be just as effective at destroying actinic keratoses. So in our office, after evaluation, our patients come in, they're incubated in our office in a private setting for an hour with topical levulinic acid. They get exposed to a blue light, receive some post-operative instructions, and are able to go right back home within a short time span. As part of the treatment, we discuss with them the protocol in terms of how they'll be treated, what's going to happen during the application, during the exposure to blue light, and then afterwards. During the exposure to blue light, we will explain to them that there is some discomfort, and this discomfort appears in the form of stinging and burning, which occurs as the light is being shined on the skin. This is because the compound which has been activated and incorporated into sun damaged cells is now destroying those cells. The stinging and burning can vary in terms of its intensity, and the more sun damage you have, the more intense the burning is going to be. Obviously, the on-label usage implies that a longer incubation time overnight should occur. In those situations, patients experienced a more intense stinging or burning simply because more of the compound had been absorbed into their skin. With the shorter incubation times that we use in our office, between 1 to 3 hours of topical application and incubation, just enough compound is absorbed into the sun-damaged cells that you don't necessarily need that longer period of time, and that translates into much less discomfort during the exposure to blue light. Now, we've also found through our experience and through experience with other clinicians that you can mitigate this burning by using such things as a fan, or in our case, we'll use a cold forced air cooling unit and allow the patient to control that and apply it directionally to his face and really calm down the burning areas as they appear. So at the end of the treatment, the burning typically subsides quickly and they get their sunscreen put on and they can go right home and they'll have experienced the worst of it. Once the treatment is done, I think it's just as important to talk to them about their post-treatment care as it is to bring up the topic of PDT in the first place. Each patient goes home with a patient care kit and instructions which explicitly tell them what to do and what not to do during the 24 to 48 hours following treatment. It's really critical, it's imperative that they understand that the compound is still metabolically active for a period of 24 to 48 hours. So being exposed to a different light source, such as everyday sunlight, can continue the process and can lead to more burning and stinging, which is really not necessary, but can make their face more red and indeed more swollen and irritated. Obviously, the gold standard for destroying actinic keratoses is the use of a blue light source that takes advantage of the absorption peak at its highest point to destroy sun-damaged cells. We tend to use blue light for patients who have a lot of actinic damage. The beauty of PDT is that the patients who have a lot of actinic damage can be exposed to blue light and they'll get a great effect. That being said, there are other light sources which can be used to activate aminolevulinic acid. Those include the pulse dye laser, which is 595 nanometer, the KTP, which is 532 nanometer, and a broadband light source, which is referred to as pulse light, which incorporates a number of wavelengths. For example, patients who have sun-damaged actinic keratoses, but also in the presence of photoaged lesions such as lentigines, which are sunspots, we might consider activating with a pulse light source, which will activate the compound to a similar degree, but also includes the benefit of being able to treat these brown spots in a cosmetically pleasing way. So the patient gets activation plus a cosmetic benefit. The same can occur in someone who has actinic keratoses in the setting of numerous blood vessels on their face. We might choose to use the pulse dye laser, which will activate the compound as well as seal the little blood vessels on their face and give a cosmetically pleasing appearance. When patients come into our office with actinic keratoses, we look at the degree of sun damage and the number of lesions they have. These are patients that have spent their whole lives in the sun and it's beginning to show 20, 30 years down the road. For patients who have not had that history and only have a few lesions or just entering those initial stages, we can identify those lesions clinically and just treat those with spot treatments such as liquid nitrogen or topicals. They're probably better served by that approach. However, we do observe them every 6 months to a year, and when they start to develop new or extensive lesions, we then discuss photodynamic therapy as the chief option for treatment. The ideal patient is one who has had obviously chronic sun exposure and has developed numerous actinic lesions all over their face. These are patients which lesional treatments like liquid nitrogen or topical treatments would be very uncomfortable over a longer period of time and require multiple treatments. So we suggest photodynamic therapy because in one treatment we can apply the compound to the entire face. It gets absorbed by all the lesions, all the ones we can see, plus all the subclinical ones which we know will form in the coming months. They can get exposure to the blue light at one setting and destruction of those lesions, perhaps an additional treatment required. It's a much simpler process and allows the patient to get a much better global result. When we discuss photodynamic therapy with our patients, first of all, they're very intrigued by this. Many have not heard of this type of treatment before. It's essentially a really novel concept to them. They've been in offices and have had treatment with liquid nitrogen, which hurts and stings, and it's not very comfortable. When they understand that there's a topical treatment which can destroy all of the sun damage potentially, as opposed to treating each individual area, they typically get very excited and interested by this. The treatment of aminolevulinic acid to the face for actinic keratosis really begins before the patient even sits in the chair. It's very important to have a thorough, documented pre-treatment protocol. And the first part of that involves washing the area of the face to be treated very thoroughly with a gentle cleanser and water. And this is typically done by the patient themselves. Secondly, the patient is brought into the room, and the medical assistant or the nurse themselves will further clean the area by scrubbing it vigorously with a cleanser like acetone, which basically degreases the skin, removes a little bit of the stratum corneum, and helps to increase penetration of the aminolevulinic acid. Following the scrub, the particular levulinic acid stick is prepared, and this is done by crushing the stick according to the protocol and shaking it together for approximately 3 minutes. And by shaking it, we're actually allowing for the compound and the solvent to mix together into a solution. So when you're applying the aminolevulinic acid into the skin, make sure we do it vigorously yet evenly, rubbing into the full face in a methodical fashion. We want to make sure that we avoid the mucous membranes, and those chiefly being the eyes and the lips. At certain points during the application, it may be difficult to judge if the liquid is actually being applied to the skin, so it's beneficial to actually depress the stick onto the skin with a firm pressure and prime the stick, so to speak, so that the liquid keeps flowing evenly. The aminolevulinic acid is then allowed to incubate on the face, and this time is variable. It really depends on what we're treating. We will allow incubation for anywhere from 1 hour for facial treatments to up to 2 hours for non-facial treatments, such as areas on the arms or chest. This really depends on the degree and location of actinic damage. The incubation typically takes place in a room with very little light, so as to not activate the compound during the incubation period. Incubation has already allowed for penetration and absorption of aminolevulinic acid into the target cells, so once incubation has been complete, the patient can be rinsed with a gentle cleanser and water. However, protocols on this vary, and some physicians prefer to do treatment with the light without having a washing beforehand. Before the patient is placed in front of a light source or laser device, protective eyewear is used. Positioning of the patient in front of the light source is very important in order to optimize exposure to the light source. The patient should be placed flush with the light and should be no more than 5 inches from the surface of the light. Exposure to light can involve different light sources, but typically exposure to blue light occurs for approximately 16 minutes and 40 seconds, during which period the unit is started and the patient is either handed a hose with a forced air cooling to be able to cool themselves, or a fan is placed close to the patient and turned on, because as the time progresses, there will be a sensation of burning and stinging, and both the fan and the cold air can mitigate that. Following exposure to the light source, we then review a post-treatment protocol with the patient. This includes applying a good sunscreen containing titanium dioxide or zinc liberally to the face, and instructing the patient to avoid direct sun exposure for 24 to 48 hours. The patient is told to expect a sunburn-like reaction, which can include some mild redness, which may progress to moderate redness over the course of 24 to 48 hours and may peak at 48 to 72 hours. During the first 24 to 48 hours following the procedure, patients are also instructed to avoid ambient light sources such as sunlight streaming through a home window or through a car windshield. As a last instruction, the patients are given a follow-up appointment approximately 2 to 3 weeks after the treatment, at which time they come in and are reevaluated by the physician to determine the success of the treatment. The use of PDT for acne is an off-label indication. There's currently no labeled indication for the use of PDT in this disease state. However, there are phase 2 trials ongoing which are attempting to show the efficacy of treatment of PDT for acne. But from the standpoint of a clinician, the standpoint of our office and seeing patients every day coming in with acne or frustrated with conventional treatments, it just makes sense to do it. The compound is absorbed in the skin preferentially by the oil glands. It's also absorbed by bacteria on the surface that can cause acne. So if you can selectively destroy both of those entities, you can definitely improve your patient's acne. PDT for treating patients with acne, the protocols are different simply because we don't need to incubate for as long of a period of time. Actinic keratoses have a scaled or a thickened, or we call a keratotic barrier to them, which requires additional time for penetration of the compound. The typical acne lesion is either a papule or a pustule or in some cases a nodule, and they don't have an associated thickening of overlying skin, so you don't have to incubate as long. You can keep incubation times anywhere as short as 15 minutes to 30 minutes and then expose to blue light to get a beneficial result. Patients that come in for treatment with PDT for acne are those patients who have just not had a lot of success with the conventional treatments. They've been to dermatologists or their primary care doctors. They've had topical medicines, whether it be topical antibiotics or topical benzoyl peroxides. They've had oral antibiotics given, and they don't seem to be getting much of a benefit or not as much benefit as they want. So when they're seeking alternative solutions, PDT is a great one to offer because this compound is typically very selective for the sebaceous glands, and we can tell our patients that it's going to almost in a sense stun or damage the sebaceous gland so it doesn't produce as much oil in response to their hormones. When that happens, we can almost say with a high degree of certainty that the overlying acne lesions will become reduced over time and improve. The application procedures for the use of ALA for acne are a little different in that we typically cleanse the face and we apply the ALA really only to the lesions. Now, if they have acne over their entire face, we may apply it to their entire face, but typically we apply it to the lesions only, what we see. Now, in acne, there are several different types of lesions. There are the inflammatory lesions, which are the red, painful bumps that we all know about from adulthood, and there's the blackheads and whiteheads. And the blackheads and whiteheads don't respond as well. These are called comedones, and they don't respond as well. So we typically don't treat people with comedonal acne. But the inflammatory acne will apply the ALA to those lesions. We'll let them incubate for 15 to 30 minutes, and then they get the blue light exposure, and that can be anywhere between 10 to 17 minutes. Because we can use ALA only in a lesional manner for acne, that gives us a little bit of flexibility with regards to the light source. We can use the blue light source, and the blue light source has the advantage of being able to treat the entire face quickly. It has the advantage of activating aminolevulinic acid both in the sebaceous glands, as well as activating endogenous protoporphyrin IX and bacteria on the skin, so it can destroy both selectively. If you have targeted acne lesions and you want to just treat those, we can then use the pulse dye laser, which gives us the advantage of a small spot size, and it's very easy for targeting individual lesions. It may be more difficult for the full face, but it gives us a lot of flexibility. As with the ALA PDT treatment for actinic keratoses, there are similar adverse events during the exposure time to light or to a laser light source. This is again related to the absorption of the compound in the skin and the destruction of these structures, which causes a burning or stinging sensation. PDT for actinic keratoses, the longer incubation times lead to more uptake and absorption of the compound in the skin, and that leads to some burning and stinging. And the longer, the more sun-damaged skin you have, or the longer the incubation time, the more it's going to sting. With acne, since there's not an extensive sun-damaged problem, the compound doesn't get absorbed as much, so the stinging and burning is only really for short periods of time, and because we're only applying it lesionally, it's even much more reduced. So we can still use the fan or some forced air cooling to keep our patients comfortable during the treatment and during the blue light exposure specifically, but the side effects aren't as bad. Now, what does occur afterwards is more of a function of adolescents or kids being kids and not necessarily following the post-treatment instructions. PDT for acne is a double-edged sword in the sense that the treatments are fairly simple, but patient compliance can be an issue. So in patients who may not be able to comply with the post-treatment instructions, such as keeping out of the sun or keeping sunscreen on post-treatment for a good 24 to 48 hours, probably wouldn't be good candidates for treatment because they'd be more likely to develop redness, swelling, and irritation after they leave your office. For patients after treatment, obviously we want them to use a sunscreen, or even better, to avoid the sun for a period of 24 to 48 hours. Now, in adults, following instructions can be much more simple to explain and to adhere to than adolescents who may not realize that being in the car for long periods of time or playing outside with their friends, even on a cloudy day, is still going to cause the compound to be activated and may still lead to more redness and irritation during that post-treatment period. Patients' response to treatment and to the whole concept of PDT for acne has been fantastic. The treatment itself involves only 1 or 2 treatments to see a good clinical result, and that happens very quickly. So when they understand they're going to get better in a much more rapid fashion, it's something to get excited about. There is some level of concern at the protocol in terms of being exposed to a light source, and so that needs to be explained, and afterwards having to avoid sunlight and avoid outdoor activities. But once that's explained, they come in, they get a short incubation time and a short treatment time. They go home, and within weeks, their lesions are getting better. And typically, this can be repeated every month, every 6 to 8 weeks, and they can maintain some clear skin above and beyond what they've had before. Now, that's not to say they shouldn't use their current medications. We always encourage patients to stay on their existing medications or put them on something for maintenance. But by and large, they're very happy with the quick results. The treatment of aminolevulinic acid to the face for acne really begins before the patient even sits in the chair. It's very important to have a thorough, documented pre-treatment protocol. The first part of that involves washing the area of the face to be treated very thoroughly with a gentle cleanser and water. And this is typically done by the patient themselves. Secondly, the patient is brought into the room, and the medical assistant or the nurse themselves will further clean the area by scrubbing it vigorously with a cleanser like acetone, which basically degreases the skin, removes a little bit of the stratum corneum, and helps to increase penetration of the aminolevulinic acid. Following the scrub, the particular levulinic acid stick is prepared, and this is done by crushing the stick according to the protocol and shaking it together for approximately 3 minutes. And by shaking it, we're actually allowing for the compound and the solvent to mix together into a solution. So when you're applying the aminolevulinic acid into the skin, make sure we do it vigorously yet evenly, rubbing into the full face in a methodical fashion. We want to make sure that we avoid the mucous membranes, and those chiefly being the eyes and the lips. At certain points during the application, it may be difficult to judge if the liquid is actually being applied to the skin, so it's beneficial to actually depress the stick onto the skin with a firm pressure and prime the stick, so to speak, so that the liquid keeps flowing evenly. The aminolevulinic acid is then allowed to incubate on the face, and for patients with acne, we allow incubation with the aminolevulinic acid typically for 15 to 30 minutes, depending on the severity of the acne and depending on the patient's skin sensitivity and the total number of treatments they may have already had. For example, if they're a new patient with acne, we'll start them slowly with 10 to 15 minutes of incubation, followed by exposure to blue light for 17 minutes. The incubation is done in a low-lit room or a room with no lighting so as to not allow activation of the compound during the incubation period. Incubation has already allowed for penetration and absorption of aminolevulinic acid into the target cells. So once incubation has been complete, the patient can be rinsed with a gentle cleanser and water. However, protocols on this vary, and some physicians prefer to do treatment with the light without having a washing beforehand. Positioning of the patient in front of the light source is very important in order to optimize exposure to the light source. The patient should be placed flush with the light and should be no more than 5 inches from the surface of the light. The patient is either handed a hose with a forced air cooling to be able to cool themselves, or a fan is placed close to the patient and turned on, because as the time progresses, there will be a sensation of burning and stinging, and both the fan and the cold air can mitigate that. Before the patient is placed in front of a light source or laser device, protective eyewear is used. Exposure to light can involve different light sources, but typically exposure to blue light occurs for approximately 16 minutes and 40 seconds. Following exposure to the light source, We then review a post-treatment protocol with the patient. This includes applying a good sunscreen containing titanium dioxide or zinc liberally to the face and instructing the patient to avoid direct sun exposure for 24 to 48 hours. The patient is told to expect a sunburn-like reaction, which can include some mild redness, which may progress to moderate redness over the course of 24 to 48 hours and may peak at 48 to 72 hours. During the first 24 to 48 hours following the procedure, patients are also instructed to avoid ambient light sources such as sunlight streaming through a home window or through a car windshield. As a last instruction, the patients are given a follow-up appointment approximately 2 to 3 weeks after the treatment, at which time they come in and are reevaluated by the physician to determine the success of the treatment. There are 3 conditions that we see in our office on a daily basis which we think are very amenable to treatment with ALA-PDT. There are 2 medical conditions and 1 cosmetic concern, which we'll talk about. The first medical condition is called sebaceous hyperplasia, and that is the presence of yellowish lesions on the face, which are essentially overactive oil glands. And the ALA can be incorporated into the oil gland through a simple short incubation time. Once you do that, and the oil gland is primed, you can then activate that with the light source. And in this case, we might use the pulse dye laser, which is a 595 nanometer laser, and it's take advantage of its small spot size and just target those lesions individually. That activates the compound, and that can actually kind of heat shock or stun the oil gland, or even destroy the oil gland, depending on the parameters you use, and that will eliminate the lesion, resulting in a smoother appearance in your skin. The second lesion is more common, and these are called flat warts, and these can be attained by children or adults at any stage in their life. These are very difficult to treat because they can be very numerous, and they can be very self-propagating. For example, if a female has flat warts on their legs and shaves, she can spread these lesions. So one thing we found is by applying ALA topically to the areas, they're preferentially taken up by the virus-infected cells that cause the warts, and then selective destruction with the light source will really reduce their numbers. The third condition we see, and especially in the South, and it's also related to sun, is called photoaging. And in patients with too much sun, they will start to develop actinic keratoses, and we've talked about how PDT can be used for that. Another condition which you'll notice on the skin of patients is a gradual browning or gradual accumulation of brown spots or sunspots on the face, starting on the driver's side where the sun is the worst and maybe proceeding to involve the whole face. These are called lentigines or lentigos, as a singular, and these can be very cosmetically distressing to patients. If you have those type of changes in the setting of actinic lesions, you can use PDT to actually treat both. So after incubation with the levulinic acid, you simply change your light source and you use the pulse light device instead of using a blue light source. Pulse light device is a type of laser light device that emits multiple wavelengths of light, the advantage of which several of these wavelengths can be absorbed by brown color and indeed by red color. So patients with these photoage lesions will get a cosmetic benefit because those brown spots will absorb the energy and peel away, in addition to the actinic lesions absorbing the energy and being destroyed. So you get a cosmetic benefit in addition to the therapeutic benefit. So patients with a lot of photoaging, it's always an option we give them to supercharge their treatments by using ALA. The future of ALA-PDT, the amazing thing is we don't really know. The use of ALA-PDT, I think we're only beginning to scratch the surface of what we can do with it. It's very flexible. It treats premalignant lesions that are of obvious concern to our patients. It also treats cosmetic issues which may not have a medical concern but have a psychological concern to our patients. It's just so flexible in what you can do with it. Every year we get more and more publications which talk about off-label indications, followed by more publications that really describe the efficacy of treatment regarding those off-label indications. So I think the future is wide open. The flexibility of ALA-PDT in our office has been really a boon to our practice. And over the past 4 to 5 years, we've been using ALA-PDT. We've been able to incorporate it into more and more conditions that we see every day. Actinic keratoses and the prevention of skin cancer are one of our primary concerns, and essentially this treatment has really revolutionized how we approach our patients in that regard. For other treatments such as acne and the development of distressing lesions such as sebaceous hyperplasia, overactive oil glands, or flat warts, and the presence of photoaging, we have been able to apply ALA and selectively treat these lesions to achieve a cosmetic benefit.